Hi, everyone. We are on a little bit of a tight schedule, and I want to make sure you all have time to ask questions. So we're going to go ahead and get started. Some more people might wander in when they have a chance. But I just wanted to reintroduce myself. My name is Lucy Schiffman, the Senior Manager of Community Engagement at Myotonic Dystrophy Foundation, and welcome to the DM2 What You Need to Know. So today's presentation, it'll be about 45 minutes, and we're going to start with a presentation followed by a Q&A. So if you have questions, please save them for the Q&A, and we at MDF will record this session and send it out to participants afterwards so that you can catch up, get the slides, whatever you need. So feel free to take notes, but we will be sending you the slides and the recording afterwards as long as you registered for this event. When we get to the Q&A, Dr. Gonzalez-Perez will call on you, and then I will be walking around with a microphone, and we want to make sure everyone speaks into the microphone so that you can be sure to hear everyone, as well as so that it's recorded for the Zoom, so that people can hear the questions when they watch later in the presentation. So this session today is provided by Dr. Paloma Gonzalez-Perez. Dr. Gonzalez-Perez is a neuromuscular neurologist at Massachusetts General Hospital, where she directs the myopathy clinic and conducts clinical research in the field of myopathies such as myotonic dystrophy. She obtained her MD at the University of Navarra in Spain and completed 2 neurology residencies at University Hospital Virgen del Rocío in Sellville, in Spain, her hometown, and then again in the University of Iowa, as well as the Mass General Birmingham Neuromuscular Fellowship. She is the recipient of a K23 award that aims at identifying non-invasive and painless biomarkers that serve to monitor the progression of muscular disease in DM. So please give a warm welcome to our presenter, Dr. Paloma Gonzalez-Perez. Thank you.
Well, thank you so much for coming, and it is my pleasure to be here with you all. It is my first time in this type of conference. You're going to notice that I have an accent, so if you don't understand something, probably it's my fault, okay? So just in the Q&A, please ask me to repeat it. And yeah, I thank you to the Myotonic Dystrophy Foundation for this great opportunity, because I think in clinic, many times we don't have enough time for you. And I think this type of conferences make the clinicians be closer to you and you closer to us also. So I'm going to do an overview of myotonic dystrophy type 2, and probably you know many things, or maybe you don't know almost anything. And please feel free to ask, okay, in the Q&A. I'll be happy to answer if I know the answer, because we don't know too many answers. Okay, these are my disclosures. You probably know that there are many studies in myotonic dystrophy type 1. I have one with Vertex, which is non-interventional. We are not testing any medication yet. I have a second one, which is the one that Lucia mentioned, is granted by NIH. It's a biomarker study that we use MRIs and muscle ultrasound to follow the muscle in patients with myotonic dystrophy type 1 and type 2. And then I have another clinical trial for another muscle disease, which is not related to DM. Okay, so I have divided this presentation in the following sections. We are going to talk about the genetics of DM2 specifically, then how in life myotonic dystrophy type 2 can affect different systems of the body, and that's why it's so difficult to diagnose sometimes this disease. When in life DM2 can affect systems of the body, and I think this is very important in this specific subtype of myotonic dystrophy, because we always have in mind that this myotonic dystrophy type 2 manifests late in life, but then we know that the younger generations of parents with myotonic dystrophy type 2 can have symptoms also early in life. And how to also tips for self-management of symptoms, and how to best work with your clinical care team to ensure the best quality of life. So let us start with genetics. Okay, so probably you know that we all have 23 pairs of chromosomes, okay? So, for example, he is what we call the human karyotype. This is the human karyotype of a male, okay? And you can see that the last pair of chromosomes is YX. That's why this is a male. All the cells have these 23 pairs of chromosomes. So what happened in myotonic dystrophy type 2, the genetic defect in this myotonic dystrophy type 2 is in the pair 3, pair of chromosome 3. And what happened there? That one component of this pair has a longer number of repeats. So these chromosomes, the DNA code is made of letters C, T, G, A. But specifically, myotonic dystrophy type 2, more than 75 CCTG repeats is what confirmed the diagnosis of this muscular dystrophy. Less than 75 is what we consider normal, but more than 75 is what we consider consistent with myotonic dystrophy type 2. Very important, and unlike myotonic dystrophy type 1, it's very difficult in myotonic dystrophy type 2 determine how long is the repeat. We know it's more than 75 repeats, but we don't know what is the maximum length because the repeat is very, very, very long, and it is very difficult in the lab to see exactly how many repeats each patient has. It's different from myotonic dystrophy type 1, that sometimes we can say, well, around 200, around 1,000. But in myotonic dystrophy type 2, we don't know exactly how many. We just know more than 75 is diagnostic for the disease. And only one copy is enough to cause the disease. So usually one of these components of the pair come from mom, and the other component of the pair come from dad. So one of them, when one of them is longer, is what causes myotonic dystrophy type 2. This looks now maybe a little bit simple, but actually very smart researchers over the years had to spend a lot of time finding this genetic defect, okay? And that's why sometimes we say research is slow, but it's very difficult. So I have summarized here a little bit the history of how they found this genetic defect. So in 1995, we already knew the genetic defect of myotonic dystrophy type 1. So very smart clinicians and researchers, Dr. Thornton and Dr. Ricker, realized that there were some patients who appeared to have a myotonic disorder, but they did the genetic testing for myotonic dystrophy type 1, and these patients didn't have the genetic defect for myotonic dystrophy type 1. Then they said, well, it has to be another gene that is explaining this myotonic disorder. They also realized that these patients didn't have the distal weakness that myotonic dystrophy type 1 patients have. So unlike myotonic dystrophy type 1, these specific patients have more proximal weakness in the arms and weakness in the legs, like here in the thighs. So they said it has to be different. So they call it, at that time we didn't know the genetic effect, but they call it proximal myotonic myopathy. So 3 years later, in 1998, Dr. Branham and Dr. Ricker started to investigate the DNA, what I showed you before, right? The karyotype of these patients with proximal myotonic myopathy. And they didn't know the gene yet, but they knew that the problem, something that they had in common, was that the problem was in the pair 3. Okay, so they were closer. And then a few years later, in 2001, Dr. Liquori in Science, which is a very prestigious journal, they published the specific genetic defect of proximal myotonic myopathy, or now myotonic dystrophy type 2, which was this repeat expansion of CCTG, as I showed you before. And the specific gene where this expansion is located is called CMPP, okay? So then you, once you identify the gene and the genetic defect, now all the clinicians like me, right, we started ordering the test, right? Okay, and then we started identifying patients with myotonic dystrophy type 2, and we want to characterize better this disease because probably it's underdiagnosed, as I will comment a little bit later. So, and then they started to realize that there are more differences with myotonic dystrophy type 1. And one of the differences is like this disease doesn't appear to affect younger people in the first or second decade of life, although later there are some reports that contradict this thinking. And actually there are some patients in the second decade of life or even in the first decade of life that can start having some symptoms of myotonic dystrophy type 2, but doesn't that is not the rule. For the most part, most of the patients with myotonic dystrophy type 2 have symptoms later in life, in the third, fourth, or fifth decade of life. And then in myotonic dystrophy type 1, we know that when the disease is inherited from mom, sometimes the disease is in the next generation, the disease is more severe and the symptoms start earlier. So in myotonic dystrophy type 2, it doesn't look it happened that way, but I and my group analyze a little bit this when the first symptom of myotonic dystrophy type 2 happened, and we saw that those patients with myotonic dystrophy type 2 who inherited the disease from mom have a very earlier symptom onset than those patients with myotonic dystrophy type 2 who inherit the disease from that. And this is based on our cohort of patients with myotonic dystrophy type 2. Also, we rescue those patients in the literature with myotonic dystrophy type 2 for who we knew the inheritance, if it was mom's side or that side. And also the Myotonic Dystrophy Foundation helped us with this research that I will show you a little bit later. So, how this genetic defect can cause the symptoms of myotonic dystrophy type 2, right? So we have this expansion, right? But how this translate in the symptoms that we see in patients with myotonic dystrophy type 2? And actually the mechanism is very similar to myotonic dystrophy type 1. So we have this expansion, right? More than 75 repeats, right? In our DNA, right? And then this produces another molecule that we're going to call RNA. Okay, so the RNA is not like a line, right? When this RNA is expanded, actually it forms like a tangle inside the cell. Okay, so this expansion is like a little bit of a tangle, and actually that's why the researchers call this tangle like RNA foci. That you actually can see under the microscope this RNA foci, which is just tangle of RNA. Okay, what happened with these tangles? Well, actually, in the tangle, there are some proteins that are very important for other genes to work, that these proteins are sequestered in these tangles, okay? And some of these proteins are MBNL. We can say, for example, is the yellow one that I draw there, or SELF1, which is the pink one that I put there, right? So if these important proteins are sequestered in these expanded tangles, they cannot work. And these two proteins are very important for other genes to express, okay? So if these proteins are sequestered, other genes, such as, for example, the chloride channel gene, cannot work. And what happens when the chloride channel gene cannot work? That can cause the myotonia. Okay, and the myotonia is this delay in relaxation that some patients have, not all, and it's very variable, right? Maybe you have it today and you don't have it tomorrow. Maybe if tomorrow is very warm, the myotonia goes away. But this is the best, we can say, genetic clinical association that we know right now is like abnormal expression of chloride channel cause myotonia. But there are others, such as, for example, an abnormal expression of the insulin receptor gene can cause the insulin resistance or the diabetes, right? Or maybe an abnormal expression of the calcium channel gene causes the muscle weakness. Or an abnormal expression of the sodium channel gene can cause arrhythmias, okay? So not all the patients have everything, okay? And we don't know actually, this is actually one of the problems with myotonic dystrophy type 2, why it is underdiagnosed and why sometimes we don't even suspect it in clinic, because it's very variable. Any patient is different from the other, and there is not like a consistent pattern that make the diagnosis easy. So, and sometimes actually, as I said, there is no clinical myotonia, right? In the clinic, we use the hammer, we ask the patient to open the eyes or the grip, and we don't find the myotonia. But sometimes that's why we do the EMG, right? We put the needle in the muscle, and sometimes we see the myotonia on the EMG. And I don't know, let's see if this Oh, okay. Well, here I was going to show you the myotonia, okay, which is actually it's not too much the image, it's more like the sound when we have the needle in the muscle, a muscle that is at rest, and then we hear the sound of revving engine, okay? So it's like boom, and actually we don't even see sometimes anything or almost anything on the screen. It's more like the sound. And then when we see that in several muscles, there is a history that is consistent. Even if we don't see the myotonia on exam, we can say, okay, maybe it's myotonic dystrophy. And depend, if it is proximal weakness or distal weakness, we are going to favor myotonic dystrophy type 1 or myotonic dystrophy type 2. Oh, no, now it's working. Exactly. Very good. Okay, so here a little bit the same. I just want to emphasize here that more than 75 repeats confirms the diagnosis, but sometimes the repeats are very, very long, even 11,000 repeats. Very difficult for a lab to determine in each patient how many repeats a specific patient has, right? So when we send the blood test or the saliva test, right, for genetic testing, we usually don't get the specific length of the repeat. And unlike myotonic dystrophy type 1, in myotonic dystrophy type 1, the longer is the repeat, the more severe are the clinical manifestations of the disease. Here, I will say it doesn't happen, but actually we don't know how long is the repeat in myotonic dystrophy type 2. So actually we don't know, to be fair, we don't know if there is any correlation between the number of repeats a patient has and the severity of the phenotype. I said there's no correlation, but to be fair, it's better to say I don't know if there is correlation because we don't know the exact number of repeats a patient has. Okay, so here this picture was done by one of our fellows, Dr. Peter Myrtle, who was training with us. Now he's a neuromuscular neurologist, and we were, we are surprised, how variable is this disease, right? And I was talking earlier today, I went to medical school, I did the residency, right? And then I go to neuromuscular fellowship, and then I focus on muscle, right? But with myotonic dystrophy, right, I have to step back and actually come back to my general medicine. Because this disease doesn't affect only the muscle, can affect many organs, don't happen in everybody, but can affect very many organs, right? For example, eyes in the form of cataracts, right? Or thyroid disease, or proximal weakness, that is something that we see in the clinic very often, diabetes, hypertension, even tumors, sometimes cholesterol, okay? And very important, and I put it here on the side, like the heart, right? Sometimes we have to think always if there is any heart problems, and even the immune system, okay? So, it's a very multi-organ disease, okay? And then the differences with myotonic dystrophy type 1, and something that I keep always in mind in the clinic, in the myopathy clinic. Of course, the myotonia, we already talked about that, could be there, maybe it's not there. In myotonic dystrophy type 1, more consistently is always there for the most part. The distribution of muscle weakness. So in myotonic dystrophy type 2, right, more proximal arms and proximal legs. In myotonic dystrophy type 1 is more hands and feet. And very important, myotonic dystrophy type 2, muscle pain, okay? So it is not uncommon that a patient who has been diagnosed with fibromyalgia comes to the clinic for muscle pain, just muscle pain. I was diagnosed with fibromyalgia, but my muscles are very stiff. It's very painful. And then we do the EMG because maybe we don't find the myotonia on exam, but we do an EMG and the myotonia is there. And actually the patient has myotonic dystrophy type 2. So muscle pain that sometimes, could be, I'm pretty sure, I'm positive that we are missing in my clinic. We are missing patients with probably, I don't know, but my suspicion is that we are missing patients that probably only have muscle pain and don't come to the neuromuscular clinic because they are not referred to the neuromuscular clinic and they are diagnosed with possibly fibromyalgia. or they come to the neuromuscular clinic when they develop some weakness or something else. And again, exactly, I would say that no clear correlation between the length of the expansion and the severity, but as I said, we don't know. We don't know the length of the expansion. And this is a little bit the work that we did last year. So when in life, myotonic dystrophy type 2 can affect the body, right? And we always said, in the third, fourth decade is basically when the symptoms start, but it's different for everybody. And in this study that we published in Neurology Genetics last year, we realized, we only included here patients. Sometimes you have a patient with myotonic dystrophy type 2 and you don't know if that patient inherited the disease from mom's side or that side, or maybe the genetic defect just is new to that patient, right? But in this study, we only included patients who knew that the disease was coming from mom or from dad, okay? So that's why you see in the first graph here, yes, show here. You see many people here, right, that started with symptoms in the first, second, and third decade of life, okay? Because what happened usually, if a patient knows that the disease is coming from mom or from dad, is possibly because the mom and the dad was also obviously diagnosed already, and it's easier to pick up the disease in the next generation if the family know that there is a genetic disease running in the family. So that's why we have so many people here with early onset of the disease. But the point here is that you can see that in red, we put those patients who inherited the disease from mom. And in blue, those patients who inherited the disease from dad. And you can see that the age at the symptom onset, okay, in those who inherited the disease from mom was earlier, okay, much earlier than those who inherited the disease from dad. And this is a little bit the same as in myotonic dystrophy type 1. And this was statistically significant. And what type of symptoms, right? Because in my clinic, when patient comes with muscle weakness and they have myotonic dystrophy type 2, many times the muscle weakness don't start in the first decade or second decade of life. They start much later, right? But the thing here is like many times, well, most of the patients had muscle symptoms as the first symptom, okay? And muscle symptoms is not just muscle weakness in this population, it's also muscle pain or muscle stiffness. And many of them only had muscle pain and muscle stiffness. But there are other patients who only had the first symptom, only had cataracts, okay? Or maybe a heart problem, okay? And they didn't have any muscle problem in the arms or in the legs, okay? So, yeah. So what we can do in terms of management of symptoms, and I think the management has to be individualized because the disease is very variable, but these authors are experts in myotonic dystrophy, and they published in Neurology Journal in 2019 a consensus-based care recommendations for adults with myotonic dystrophy type 2. I have to say that in myotonic dystrophy type 1, another group of experts published recommendations for pediatric myotonic dystrophy type 1 and adult myotonic dystrophy type 1. In myotonic dystrophy type 2, we only have, as far as I know, recommendations for adults with myotonic dystrophy type 2. But in view of the new papers that are coming, reporting that this disease may start earlier than we thought, maybe in the future years, we're going to have a consensus also for pediatric is less than 18 years old, right? So I would say pediatric patients with myotonic dystrophy type 2. And so let's focus on this consensus that basically they address different organs of the body. And as I said, I think you also have this in one of the tables outside, a summary of the recommendations. I think one of the most important things that even if if the patient with myotonic dystrophy type 2 don't have symptoms, we always check the heart, okay? So at least an EKG, a diagnosis, and maybe annually, or every 2 years, if the first EKG is normal, is recommended. And of course, all my patients over the age of 40 years old, if always a referral to cardiology, or if the EKG is abnormal, a heart doctor has to be on board. Then the breathing. Not everybody has breathing problems, but at least some baseline breathing testing at the beginning, and then depend how the symptoms go, if the patient have symptoms or if the breathing testing is abnormal, that baseline breathing testing, we may need to refer the patient to the pulmonary doctor. Sometimes it's not only the pulmonary doctor, sometimes has to be a sleep doctor because maybe the breathing is only at night, right? And then the patient wake up in the morning with morning headaches because they were not breathing well at night and they need maybe some CPAP or a BiPAP, or maybe they sleep during the day too much and they need a little bit, a medication to be more awake. So all that is in the breathing category. We may need some doctors that help us there. And always recommended all the vaccinations that are recommended for general population, and also like the flu every year or the pneumococcal vaccine also to prevent infections. In terms of the pain and muscle weakness, careful with the pain medications, because sometimes there are pain medications that actually make your breathing muscles weaker. For example, the opioids. We also recommend physical therapy and occupational therapy, orthosis braces for those patients who need it. Massages are always great, right? And heat, ice, chiropractic therapies always with help, may help, but always with caution. And it's good to go to a good one. And don't start like a crazy exercise regimen, right? Without a cardiac evaluation first, right? Obviously, to do exercise, your heart has to be in a good condition, right? So always have your cardiology doctor or at least your PCP and your neurologist on board and see what type of exercises can help. In terms of the myotonia, I have to say that many times myotonia is there, but the patients don't complain, I think, about that in my clinic. So many times, even if the myotonia help you for the diagnosis, but many times don't bother the patient. If don't bother, we don't have to treat the myotonia. If it bothers, because maybe it's very prominent, which is atypical in myotonic dystrophy type 2, is more a problem in myotonic dystrophy type 1. But there are medications for myotonia, medications like mexiletine. But again, the heart has to be checked because mexiletine can also cause heart problems. Mexiletine can also help a little bit with the muscle pain. Sometimes muscle pain comes from this myotonia, but the heart has to be checked. The eye, right? Cataracts. And actually, the cataracts that are seen in myotonic dystrophy type 2, sometimes is the first symptom. Sometimes the ophthalmology team see patients with myotonic dystrophy type 2 even before us, but maybe the diagnosis is not made at that time. And actually the cataracts are very, sometimes are very atypical. They have like a Christmas tree shape cataract, and that should bring the bell for myotonic dystrophy type 2. And sometimes there is a little bit of droopy eyelids that many times don't bother the patient. If don't bother the patient, that's okay. Some other times, if it is very prominent, the droopy eyelid, so they can do a little bit of surgery to open the eye a little bit more. And then GI problems, right? Sometimes the swallowing is a problem, and then this brings some weight loss. And if there is weight loss, right, the muscle maybe can be weaker. Or some other patients have what we call irritable bowel syndrome or diarrhea and constipation, periods of diarrhea and periods of constipation or abdominal pain. And then the brain, right? Brain could be in the sense like mood or cognitive problems or just apathy, right? Like the patient don't have energy or don't want to do anything during the day. And there are medications, but medications are needed and sometimes, and they are great, but also sometimes I favor many times, sometimes the cognitive and the behavioral therapy, the same as the physical therapy for the muscles or the occupational therapy, also for the muscles. Also, we have cognitive and behavioral therapy that can help with the daily function. And then hormones, right, can be also affected in this disease. So, for example, the diabetes, right, is a problem with the insulin, or the thyroid, right, can be also affected, or sex hormones like infertility or erectile dysfunction very early, or abnormal menses. And then we also investigated the frequency of tumors in myotonic dystrophy type 1 and type 2. And we saw that it's very important. It's very important for everybody, but specifically for myotonic dystrophy, to be compliant with the malignancy screening for general population. Okay, so the mammograms, the colonoscopies, the pap smear, all that very important. Plus, according to our study that we published in Muscle and Nerve, I think 2 years ago or 1 year ago, also skin tumors, which are very frequent, but skin tumors we saw that they are more frequent in myotonic dystrophy than in other muscular dystrophies. So I always recommend skin checks by PCP or by the neurologist, or if there is any concern, also by the dermatologist, obviously, and check the thyroid, okay? Because we also see some, for the most part, benign tumors, but sometimes a little bit more. Yeah, go ahead. Skin. Yeah, I knew that my accent was going, I was lasting too much. Skin tumors. Yeah, I always recommend some skin checks. It doesn't have to be, obviously, annually. I mean, it depends what the doctor says, but usually the PCP and the dermatologist, better than the neurologist, can help with that. And then anesthesia, right? Every time a patient is going to have a surgery, right, or a procedure, and general anesthesia is going to be used, I ask my patients, okay, print the anesthesia recommendations that you can find in the Myotonic Dystrophy Foundation and share with your surgical team. And many times, I think it's important to communicate with the surgical team, not only the patient, obviously, but the neurologist or the family doctor, to communicate with the surgical team, because I think they appreciate a little bit of a conversation and not only a paper that many times you don't read it completely. So very careful, right? Especially, all these sedatives that have a long half-life, and in patients with myotonic dystrophy, they can take longer to wake up, and the extubation, when they take the tube out, maybe they have to wait a little bit more than in a person without myotonic dystrophy. Okay, so how to best work with your clinical care team to ensure the best quality of life? And I think this is the problem that I see with in my clinic or with this muscular dystrophy. It's like we are seeing the tip of the iceberg. So if the patient has muscle weakness, of course the patient is coming to the neuromuscular clinic. If the patient doesn't have muscle weakness, maybe there is a doctor there that says, could be a muscular dystrophy, but maybe, I'm pretty sure we are missing patients that are with other doctors that are not referred to the neuromuscular clinic because they don't have a muscle weakness, or maybe because they have only muscle pain and they are diagnosed with fibromyalgia in the rheumatology clinic or fibromyalgia with the family doctor. And so I think in myotonic dystrophy, it's very important, this triangle of the neurology team, the patient, and the family doctor. And then, even if the patient don't complain or we don't see anything concerning for heart or for breathing or for anything else, we need to dig in and go to the deep iceberg and see, is the heart okay? Is the breathing okay? And once you have your baseline workup done, it doesn't mean like we have to repeat that every year or anything like that. We have to individualize the care. But I think it's good to have the diagnosis because it's good to know what to expect and what we need to monitor. And with that, I just want to say thanks to you all and also the patients and families, obviously. My clinic is at Massachusetts General Hospital. Here is my email. And if you are interested, of course, in the clinic, you have there the number of the clinic too. I work with a clinical research coordinator who handles a little bit all my research and she is Blanca Escoriaza, and her email is there in case you want to know a little bit more about our research options. And as Dr. Wheeler mentioned before, he is also at Mass General Hospital, but we work with Beth Israel Deaconess Medical Center and Boston Children's Hospital. And thank you so much for the attention. Yeah, thank you. Bye.
Thank you so much. So I saw a lot of you taking pictures. Just a reminder, you will get this via email. We do have about 8 minutes for Q&A, and I just want to remind you to wait to ask your questions until you're speaking into this microphone. So if you have any questions, I'm happy to bring you the microphone.
Hi, my name is Lynn. I was wondering, has there been any research on the cognitive effects from myotonic dystrophy type 2? I'm 56 and I actually just had to leave my job as that was like my main component. Forgetting, can't master new skills. I guess the higher level of organization is just totally shot. I did have a neuropsych exam 2 years ago, and they did find some cognitive difficulties that they felt were related to the type 2. And I actually am going to be having another one in June to see if there's any. But I was just wondering if there's been any research on that.
Yeah, yes, there has been research, I would say descriptive research, like, doing MRIs, brain MRIs in patients with myotonic dystrophy type 1 and type 2, and some MRI studies is what I will say. And not in myotonic dystrophy type 2 as far as I know, but it's been, I think Dr. Wheeler actually is doing some research in myotonic dystrophy type 1 for the cognitive problems that these patients have with lumbar puncture, like taking a little bit of fluid from the CF and analyzing that fluid. I think that is right now on type 1 only. In terms of type 2, for sure, muscle MRIs and, brain MRIs and neuropsychological testing has been done. And you cannot do the MRI. Yeah, exactly. And in a CT, you don't see, usually in the brain MRI, sometimes they see this, what we call white matter disease, that it's very unspecific, to be honest, but apparently it's, patients with myotonic dystrophy type 2 are at risk of having this white matter disease than in patients without myotonic dystrophy type 2. But I will say clinical research, but descriptive. I wouldn't say, nothing else as far as I know.
I do too. I went to Wake Forest, and that's where I had a cognitive testing done. I'm over here. And so, I know you said you can't do the MRI because of the pacemaker, but they, one part of it was an MRI. Another part of it was like squeezing the thing and doing some physical fitness testing, and then some, oh my gosh, you had to repeat things and count backwards and do all kinds of stuff. It took me, I was there all day. And then I didn't do the spinal tap because I had one at Leahy and I didn't have the greatest experience. So I didn't want to fly home to Boston after having a spinal tap, but they did all that at Wake Forest. They were doing a special Wake Forest in North Carolina, Raleigh-Durham, North Carolina.
It's actually Winston.
Winston, yeah.
I see. Sophia is our research coordinator.
And then I did have a question though for the doctor too, real quick. Are you accepting new patients?
Yes, of course.
Okay.
Yeah.
Yes. I want to transfer from my existing.
One second, Sophia's our registry coordinator, and she knows.
Just to say about this study, thank you for mentioning that. That's called the BRACE study. So I can show you afterwards in our website, but if you go to our website under our clinical resource center, all these studies are mentioned. Actually, I think I had some flyers and I didn't bring them, but we can go into that. I'll show you that. Thank you.
Mm-hmm. Yeah, the phone of my clinic is there, and you're going to have the slides, and feel free, you have my email there too. So.
So we just have time for about probably one more question, maybe two.
Hi, I wanted to know if there was any research in preventing myotonic dystrophy, specifically type 2 in my future generation.
Preventing?
Yes.
Preventing the symptoms, right? So someone who has the genetic defects, right? Preventing the symptoms. Actually, this in terms of research, we are well, this is the thing. So because this disease is so unpredictable, right? What we're going to prevent? The cataracts, the muscle, the brain. So right now, part of my research starts from that idea. Like right now, the biomarker study that I have at the MGH is we do muscle MRI, muscle ultrasound, and electrical impedance myography in patients with myotonic dystrophy who don't have muscle weakness, almost. Okay, so because we want to know an earlier biomarker that is gonna predict who is gonna develop muscle weakness, right? Because there are patients that only have muscle pain and stay with muscle pain for many years. Why those patients are different from the ones that are having muscle weakness. So long story short, so we don't know how right now how to prevent, but it's basically we don't know what to measure. I don't know. So right now, on my side, we are studying the muscle when it's not affected yet clinically, when the patient doesn't have still muscle weakness. So how that muscle look on imaging, okay? And we do this type of imaging every 6 months, okay? Not only myotonic dystrophy type 2, but also myotonic dystrophy type 1, because we want to know the muscles in myotonic dystrophy type 1, right, are more affected here and in the lower leg, right? And myotonic dystrophy type 2 is here. So how the muscles, why is that, right? Why myotonic dystrophy type 2, these muscles are very good, okay? And these are affected. So we want to do longitudinal studies before patients develop muscle weakness to see if we have something that tell us, if you see this patient goes with muscle weakness in the future. But if you don't have this patient don't develop muscle weakness. If we have that, we can say, okay, so let's do this, or let's target this in this population of patients who are going to develop muscle weakness. But we don't even have that right now. This is in terms of muscle weakness. And then all the other things that, for me, the heart is the most important thing, right? It's like, okay, muscular dystrophy affect the heart. So let's look the heart. All the other things, the cataracts, well, is something that you can have corrected, right? Other things, how to prevent that. Probably we are not doing enough research on that, but also because it's fixable, right? We are more focused on brain, on muscle, and definitely on heart. So very low threshold, right? To do pacemaker, to place a pacemaker or something like that. If we have any abnormality on EKGs, right? Yeah. Very good question. Yeah.
Thank you so much. I want everyone to give a round of applause to Dr. Gonzalez-Perez. We are out of time right now, but at the end of the day, you will see in your agendas that we have a Stump the Doctor session with Dr. Gonzalez-Perez, and you'll have the opportunity to ask more questions then, almost the entire 45 minutes of that session. So thank you.
Thank you.